Hello and good evening, everybody. I'd like to welcome all of you on behalf of Cornea Society of India. First of all, a new beginning, new day, and new format. A Friday night journal club. That's something which we are starting today, and that was new thing. This year we were deciding about coming up with new ideas of involving people and also having more interaction about science and about different part of cornea and ocular surface. And we thought, why not journal club? And then we thought, like, how do we start? And then we had a discussion and we realized that one of our member was already doing it for some other society, Maharashtra Ophthalmic Society. And we didn't have to go further to approach Parul. And Parul came into picture and we asked Parul that, would you be interested to coordinate Journal Club for Cornea Society of India? And she was really graceful enough to take another responsibility on top of what she would have. Our own Dr. Nikhil decided to pitch in with his expertise in same subject to coordinate from the CSI side. And then they came up with the team of people who were like right on top of their game in the same subject, namely Dr. Praful Maharana, Dr. Jayesh Wazirani, and Dr. Aditya Pradhan. You all know them, and all of them are really good at evaluating articles, talking about the evidence and all such things. And who all can make a better team than this thing? And they came up with the entire concept of Kera Journal Club or Kera JC. This would not be just limited to presentation of articles, but we are considering many more ideas further to give you update about the recent published articles, small reviews about that, and many more activities which we would be doing. So without further ado, I would invite Dr. Nikhil Gokhale to take forward the proceedings from here.
Thank you, Himanshu. So today we have a interesting journal article that we'll be discussing. I'll ask Aditya to go ahead and introduce all the panelists, faculty, and maybe Sapna can then start.
Yeah, thank you, sir. And we all know that ocular burns are a true emergency which we face in our clinics, and prompt treatment gives to the most optical optimal outcomes for both the surgeon and the patient. So the article in question, which we'll be discussing today, deals with the tenonplasty, which is combined with the amniotic membrane transplantation for patients who presented with severe ocular burns and anterior segment necrosis as well. To take this article forward, we have a great team lined up. The panelists are Dr. Geeta Iyer, Dr. Bhaskar Srinivasan, and Dr. Sayan Basu, who will be all supported and joined by the executive committee members of the Cornea Society of India. And the article shall be presented and discussed in great detail by Dr. Sapna Kini, who is from Mumbai. So, and followed by a video demonstration of tenonplasty by Dr. Geeta, and also some tips and pearls on statistics by Dr. Maninder Sethia. So without wasting any more time, I would like to invite Dr. Sapna to share her screen and start the presentation.
Good evening, everyone. I would like to welcome you all for this very first session of Kera JC. I'm Dr. Sapna Kini, and at the outset, I would like to thank Dr. Parul, Dr. Nikhil, and all the team for giving me this opportunity to discuss this article today. So the article that we are going to discuss today is tenonplasty combined with amniotic membrane transplantation for patients with severe ocular burns induced anterior segment necrosis. This is by Wen Yan Peng et al., published in the Journal of Burn Care and Research 2020 May-June edition. As we all know, ocular burns form the major ophthalmic emergency and account for around 11.5 to 22% of ocular injuries. And alkali burns are most common, around 60%, and remaining are the thermal burns and acid burns. These severe burns are complicated with the anterior segment ischemia, extensive necrosis, and even corneoscleral melting. So appropriate management and intervention in the acute stage dictates the final outcome, as well as the prognosis for visual rehabilitative procedures in the chronic stage. So it is very important to take the right decision in the acute phase itself. So the acute phase of ocular burns, our main aim is to attain ocular surface stability as soon as possible to prevent further visual threats. As we all know, amniotic membrane transplant, due to its anti-inflammatory and anti-fibrotic properties, the amniotic membrane helps in promoting the corneal reepithelialization, acting as a patch, and it also helps by replacing the necrotic conjunctiva and superficial cornea by acting as a graft. But we have seen that it fails to repair the conjunctival defects when there is underlying sclera is ischemic. So in such cases of severe burns with scleral necrosis, tenonplasty is advocated. Tenonplasty helps to repair the necrotic conjunctival surface by separating a layer of vascularized tenon's tissue from adjacent area to cover the ischemic sclera. So this also helps by offering as a bridge for migration of conjunctival and limbal-derived epithelial cells. The only problem is in large scleral necrosis, this conjunctival repair is challenging due to shortage of the tenon's tissue available in patients with severe burns. So this novel technique of combined tenonplasty and amniotic membrane was studied for successful repair of intractable corneoscleral necrosis caused by severe ocular burns. So this study was done in the corneal division of Zhongshan Ophthalmic Center at Sun Yat-sen University, and it was studied during October 2012 to August 2018. It was a prospective case series. Informed consent was taken and advantages and disadvantages explained to all patients. All the patients included in the study had severe sclerocorneal ischemia due to chemical or thermal burns. They had received emergency treatment, including copious irrigation, intensive short-term topical steroids, lubricants, and focal antibiotic drops to prevent secondary infection and promote reepithelialization before enrollment in the study. All these cases showed no signs of infection, and so no microbial cultures were conducted. The inclusion criteria that were considered was recent history of chemical or thermal eye burns, adult patient with persistent corneal epithelial, conjunctival, and Tenon's tissue defects, as well as ischemic sclera. Circumference of at least residual healthy corneal limbus greater than 2 clock hours was required. Treatment history of one or multiple patchings with amniotic membrane was there, and a failure of systemic administration with vasodilators and topical agents to promote epithelial proliferation for more than 2 weeks. All cases who had suspicious ocular surface infection and those who had uncontrolled hypertension, pregnancy, or history of thromboembolic events were excluded. Now, looking at the surgical method, it was done under retrobulbar anesthesia and topical anesthesia with proparacaine, and necrotic superficial sclera and corneal tissues were excised. The residual Tenon's tissues from adjacent to the defects were separated and relaxed to cover the ischemic scleral surface with atovicryl interrupted sutures. And after the exposed Tenon graft and corneal surfaces were covered by a sheet of cryopreserved amniotic membrane with the epithelial side up. So looking here, this was, if you look here, this is the necrotic area with the epithelial defect. So this was the conjunctival margin was dissected, and then the Tenons from the posterior side around the equator was pulled up to the limbus, and it was sutured with atovicryl interrupted sutures. This is how the Tenon's area was covering the ischemic sclera, and then after this defect was covered, this amniotic membrane was put with the epithelial side up with the atovicryl sutures at the conjunctival margins and tenonylon sutures at on the cornea. The eye was patched, and on post-op day 1, BCL was applied. In the post-operative treatment mentioned in the article, they have just given oral doxycycline 100 milligram twice daily for 10 days and topical sodium hyaluronate eye drops. Post-operative examination was done on day 1 and 7, and then weekly for 2 months, every monthly for 6 months, and then every 2 months thereafter. In the follow-up visits, best corrected visual acuity, digital photography, and other regular examinations were performed. In the follow-up visit, the amniotic membrane on the cornea was trimmed along the limbus if the corneal surface was re-epithelialized or the amnion was collapsed from the cornea. And the criteria used for ocular surface stability were re-epithelialization of the ocular surface, repair of necrotic tissue, and fading of ocular congestion. Visual acuity of less than 20 by 200 was given value of 2, counting fingers 3, and hand motion of PL of 4 for the Logmar algorithm. In this study, 19 eyes of 15 patients with severe ocular burns induced anterior segment necrosis and corneal epithelial defects were included. The mean age group was around 46 years, and one patient had thermal burns, 2 had acid burns, and all other had alkali burns. All the patients had received one or multiple amniotic membrane patches. The burned ocular surface was stabilized within 26 to 156 days. With the article mentioned that all the cases were successfully reconstructed with no corneal or scleral perforation. At the final visit, all the corneas were opaque to different degrees and featured with peripheral neovascular vessels. Focal pseudopterygium was seen in 5 eyes, secondary glaucoma in 7 eyes, secondary cataracts in 8 eyes, and mild symblepharon in 3 eyes, and eyelid entropion in 5 eyes. The mean best post-operative best corrected visual acuity was 2.87 logmar. Now, this is the information of all the patients. We see mainly the limbal ischemia ranged from 3 clock hours to 10 clock hours. At least 2 clock hours of healthy limbus was there. Then the duration between the injury and the surgery ranged from 3 days to 91 days. And the duration of ocular stability was from 26 days to up to 156 days. This is an example of one case, who had an alkali burn with conjunctival defect and scleral ischemia from 3:30 to 9 o'clock position. And there was staining of inferior cornea as well as the conjunctival surface. And this is how it appeared after successful reconstruction with amniotic membrane and tenonplasty 45 days post surgery. So it was healed with opaque vascularized cornea with peripheral vessels with negative fluorescence staining, and achieved a best corrected visual acuity of counting fingers at 30 centimeters. This was another case with a history of liquid aluminium burn presented with conjunctival defects and scleral ischemia from 2 o'clock to 5 o'clock position, and temporal corneal epithelium was defective. And after successful stabilization, it took around 54 days. It presented with focal pseudopterygium and a secondary cataract with vision improving to counting fingers 20 centimeters. So mainly severe ocular burns are serious injuries and have poor prognosis, mainly with scleral and corneal necrosis. So the main aim is the necrotic material should be debrided and the ocular surface reconstruction is required as soon as possible to prevent eyeball from perforation and to make the ocular surface stable for subsequent treatments to recover the vision. So amniotic membrane helps by promoting epithelial differentiation and proliferation, inhibits the corneal neovascularization, and facilitates anti-inflammatory and antifibrotic activities. But we saw in this study that even repeated amniotic membrane transplant was failed in cases, even though they had some partial healthy limbus, and in cases with grade 4 injuries, burns. The amniotic membrane fared well for grade 2 to grade 3 burns, but grade 4 and above, the failure was seen, and this may be attributed to the destruction of the episcleral vasculature. So if you want the amniotic membrane to benefit, it will be benefited only if the ischemia is addressed by tenonplasty. So there is a need to identify the presence of scleral ischemia and address it as early as possible. So tenonplasty provides a vascular pedicle over which residual conjunctival cells, if any, from the fornix migrate and heal the conjunctival defect. So it was a globe-saving procedure. But in cases with diffuse burns, it was seen that the granulomatous conjunctival border was there, which could have been a risk for delayed reepithelialization due to dysfunctional conjunctival and corneal stem cells. Then tenonplasty was found to be a priority in maintaining the globe integrity, because persistent corneal and scleral epithelial defects usually lead to perforation, mainly after severe burns, and delay in the treatment can result in visual loss as well as loss of the eye. So in this study, they combined both the techniques of tenonplasty as well as amniotic membrane transplant, and they found that it improved the survival of the amniotic membrane graft, reconstructed the conjunctival as well as the corneal surface, and the amniotic membrane also reduced the corneal inflammation and promoted the stem cell proliferation. In cases with diffuse scleral ischemia, when it's more than 2/3, the Tenon's tissue is not sufficient. And in cases with the total limbal stem cell deficiency, we know that the standard therapy is to use heterologous or cultured stem cell transplants. But there is a high risk of rejection during this early phase when there is a severely inflamed eye. So this tenonplasty and amniotic membrane combined surgery can be performed at low cost in all the hospitals involved, including the developing countries also. In this study, they saw that a symblepharon formation was seen only in 3 patients, and mainly in these cases, the scleral burns were closer to the fornix. And they suggest that even the amniotic membrane graft may help in promoting the epithelial growth to a greater extent rather than an alternative conjunctival graft. The BCVA was reduced from 2.83 to 2.87 to 2.83 logmar, and this could be attributed to the corneal opacity, secondary glaucoma, and the cataracts that had developed. So to conclude the article, combination of a large sheet of amniotic membrane with tenonplasty could facilitate reconstruction and promote stability of a burned ocular surface. Amniotic membrane acts as a graft for the conjunctival reconstruction and as a patch for corneal surface reconstruction. The separated Tenon's tissue supply good nourishment to the ischemic sclera and the transplanted amnion. This technique can also be used to treat scleral melting in other surgeries like post-pterygium surgeries. And but the impact of this was not discussed in this on further visual rehabilitative procedures was not discussed in this article. So I would like to discuss at the end after discussing this reference article also. So this reference article was on tenonplasty, a new surgical approach for treatment of severe eye burns by Kukel-Korn et al. And in this, they studied 59 patients with severe burns and ischemia and necrosis of conjunctiva and sclera. These patients were treated with tenonplasty. As we all know, the principle of tenonplasty is based on plastic operation in which the vital connective tissue of the orbit is used for the vascular supply. So the tenonplasty was successful in building up the connective matrix of the globe after removal of necrotic and inflamed tissue, and there was no new scleral ulceration or even the existing scleral ulcerations healed, and the conjunctival surface could be restored in all the cases. The source of the conjunctival epithelium would have been from the depth of the fornices, where some cells survived in the depth of the conjunctival crypts. But this article also discusses the adverse effects or the drawbacks that were seen, in which they have shown that ischemic necrosis of advanced flaps was there in 7% of cases, which was seen 7 to 10 days post-surgery, and mainly it was in the inferonasal quadrant, which they mentioned was also difficult to dissect the tenons in this area, as the inferior quadrant is suffers the most damage during chemical injuries. Then there were cases of revision surgeries in which it was done with new tenons flap in 7 cases, and pedunculated conjunctivo-tenon flap was done in 10 cases. Primary regeneration of the corneal surface was seen in 30.7% of cases. While other 26.6% of cases of cornea was sealed with glue on contact lens before perforation, and a few cases, 42.7% cases, required PKP either subsequent with the tenonplasty or subsequently for tectonic purposes. So the complete epithelialization, after complete epithelialization, the conjunctival matrix is seen up to the limbus, and it prevents the scleral ulceration or also helps in healing the scleral ulceration. This technique, this paper also describes the technique of tenonplasty beautifully. In this, mainly the necrotic tissue is removed from the conjunctiva and sclera, and the tenon tissue is bluntly separated from the equatorial region of the globe and from the extraocular muscles. It is important to keep its blood vessels intact and to prepare the tenon sheet with a smooth surface, because this helps in regenerating the conjunctival epithelium that has to slide on this layer. Then the elastic tenon flap can be moved to the limbus and sutured to the sclera for revascularization. So it is important to go as deep as possible and up to the equator. And as we will see in the video by Dr. Geeta, then in all the cases, scleral ulceration healed, although regeneration of conjunctival epithelium on the tenon layer always occurred rapidly. The cornea was completely covered by new epithelium only in few cases, around 30 to 31% of cases. And in these cases, artificial epithelium was transplanted early. This is one more article by the same group, which discusses about the long-term results of tenonplasty in the treatment of severe ocular burns. So in this also 50 patients they had studied who were treated with tenonplasty, and surgery was done 3 to 126 days after injury. The epithelialization of the sheet was complete within 21 days in 79%, and all eyes up to 51 days. All these eyes, corneoscleral ulcerations were prevented or healed if existing. But in 48% of cases, isolated symblepharon formation or severe scarring was seen, which was developed within the 3 months after tenonplasty, and it did not increase after the 3 months. Now, in these cases, restoration of conjunctiva was achieved by transplantation of autologous conjunctiva or a nasal or buccal mucosa. And spontaneous epithelialization of cornea was achieved in 25.8%. So tinanplasty proved to prevent early necrolysis of the anterior segment in severe burns cases, and but the prognosis for the corneal surface healing was only seen in 25.8% cases, and even after penetrating keratoplasty, these eyes had some surface related problems. This was one more article in which they by Tabby et al., in which they studied selective localized tinanplasty after seeing the findings on ocular surface fluorescent angiography. So in this, they used fluorescent angiography to localize the areas of ischemia, and selective localized tinanplasty was done. So tinanplasty was not done in all the 4 quadrants, but it was done in the quadrants where ischemic areas were seen in angiogram. And after surgery, 1 week later, again the angiogram was repeated, and it showed perfused ocular surface in all these eyes, except for one eye, in which they found clinically that there was retraction of the Tinan's flap. And then after resurgery, the recirculation was detected in that quadrant. So none of the eyes in this study also perforated during the follow-up period. So this was a small study of 6 patients. This is one more related study in which the effect of tinanplasty in the further procedures for visual rehabilitation with Kepro is seen by Dr. Geeta, Dr. Bhaskar and all. And in this, the eyes with a severe chemical injury, they had done tinanplasty, and they have shown that how treating the it helps in treating the ischemia, the epithelial defect, and exposure. All these issues are addressed by means of tinanplasty and amniotic membrane, and if required, keratolimbal or MMG autograft and tarsorrhaphy, that can help in having the anatomical integrity of the globe, salvaging the eye, and so will have a good visual outcome during rehabilitation. So after reviewing all these articles, what I would like to infer is scleral ischemia is of course an important prognostic factor while considering the management of chemical injuries in the acute phase, and as immediate treatment also determines the final outcome, it should be diagnosed and graded in the initial presentation itself, so that we can decide upon the mode of intervention, whether we require an amniotic membrane transplant alone, a combination with tinanplasty, or if required in certain cases along with Alosled. So that can help in having better ocular surface stability, preserving the globe, and so we get a best possible final outcome in a visual rehabilitation procedure. So amniotic membrane with tinanplasty seems to be a good combination and a globe saving procedure, but whether it is enough to heal the corneal surface also is and whether it excludes the need for other additional procedures like tarsorrhaphy and epithelial transplant is what I fail to understand, because in our main article they have not shown any complications, and they have mentioned that all the corneal as well as the scleral surfaces healed well, while in the other articles they have shown that the tinanplasty could achieve around 30 to 31% of surface reepithelialization on the corneal side, while the scleral surfaces healed well in all the cases. So that was one thing. If we look at this study in the MARI format, the study question was well defined, inclusion and exclusion criteria were also well defined, and the period was well defined. It was a prospective study. The cases that were assigned in that cases with 360-degree limbal ischemia were not included. So maybe the results could have differed because the tinanplasty is difficult in such cases. And also they didn't include the pediatric age group, only the adults were included. So maybe that could also affect the results. Then assessment was done subjectively, and objective tests like fluorescent angiogram was not used to assess the scleral ischemia and the reperfusion. And even the role of post-operative steroids is not mentioned in the article. no statistical tests were applied. Long-term follow-up of this study is lacking. That what effect it had on the final outcome, visual rehabilitative procedure, that is not mentioned, discussed in this article. And this we can use this technique for preserving the globe integrity in severe ocular surface burns if we combine amniotic membrane and tinplasty both. So now I'm still left with a few queries which I would like the panelists to discuss and explain us that what is the earliest timing of tinplasty, because in all these articles it is very varying and they have not mentioned that whether we can go directly for tinplasty or we should have a trial of amniotic membrane transplant first always, and then if it does not heal then only go for tinplasty with AMG. Then what would be the role of post-operative steroids, as it was not mentioned in this article, and role of additional tarsography, and how do we secure this amniotic membrane and tinplasty, whether it is better to use fibrin glue or better to use sutures, whether vicryl or nylon, depending on the inflammatory response that we get, as it's these are already inflamed eyes. And also technique of tinplasty when the almost 360-degree limbal ischemia is there, then it is difficult. So we would like to learn that. And what are the complications that you all see in tinplasty more commonly? Because the main article didn't mention many, but the review articles, they had cases of retraction, increased sembleflon formation, and like in the selective tinplasty, they mentioned that it also has the advantage of reducing the symblepharon formation by using tinplasty only in selective quadrants rather than a generalized tinplasty. So whether that is practically seen, and what is the role of tinplasty alone in corneal healing, whether it helps totally in corneal surface reepithelialization, or adding the amniotic membrane was just the factor that helped in this study, that all the cases healed on the corneal surface also. That is what I would like to learn from you all. Thanks a lot for your patient hearing.
Aditya, so we want to have the Geeta's video now and then discuss.
Yeah, I think we can maintain the flow and then take the questions after that.
So Dr. Geeta, you could present the video and then we'll have discussion on various questions which she has raised.
Good evening to one and all. I think an excellent presentation by Sapna. You very beautifully highlighted the paper that is being discussed. Just a second. Okay. So I will very briefly show you a few situations where we have used tinplasty in the management of acute chemical injuries. And before I actually go into the actual video of tinplasty, this is something that we never tire of showing. But these are the I's and E's that need to be managed in any case of acute chemical injury, whether it be the inciting agent, the inflammation, the epithelial defect, ischemia, the variations in the intraocular pressure, and the exposure. And having to address each of these issues in patients with chemical injury will probably also answer most of the questions that Sapna raised at the end of the paper presentation. And we are going to focus primarily on ischemia over here. So I've just put together a few pictures post-chemical injury of varying grades of ischemia. We don't really have any defined way in which we grade ischemia following a chemical injury. So you could have a localized ischemia, you could have it a little more than just localized to one quadrant or a few clock hours. And you could have what we call as a generalized or a global ischemia that can occur in these patients. And usually ischemia will always be associated with an overlying defect. We've already heard about the effects of ischemia and how we need to address the scleral ischemia because of the harmful effects of the ischemia on the sclera as well as on the cornea. So the classic technique of tenonplasty that Sapna described was put forth by Rhyme et al. And very beautifully again described in the paper that she presented as an additional review paper in her presentation. And so with that, I will now move on to a tenonplasty in a chemical injury patient, and I will just share this video. So this is a patient who had extensive scleral ischemia, and this was post acid injury, bilateral acid injury, and we did a tenonplasty in both the eyes. You can see the extensive ischemia. This was a tenonplasty that had already been done elsewhere before the patient was referred. And this is the tenon's tissue that is being dissected. As you can see, even if it's 360 degrees, you can go right posteriorly as much as up to the equator. It's important to excise all the necrotic tissue. She already had an amniotic membrane over the tenonplasty. The tenons had retracted. This is the tenons that's now being pulled forward, and I'm placing it at the limbus, ensuring that you're not really causing any shortening of the fornix. It's the fibrin glue that is being first used to secure the tenons in place, and at the just bring it forward at the limbus. So it's not like if it is generalized, you cannot do a tenonplasty. You can do a tenonplasty. Tenons is available in plenty in the eye, irrespective of the extent of chemical injury. The tissue that I'm holding with the other forceps is the old amniotic and the conjunctival tissue in the fornix, which we're pushing back. The basic aim of doing a tenonplasty, when you're doing it, you need to ensure that you don't shorten the fornices when you're pulling the tenons ahead. This was a hypotonic eye, which is the reason I'm not making relaxing incisions in the tenons to advance it forward to the limbus. But this is basically how you bring the entire tenons and then secure it. Don't make it very thick and bulky that you end up having a step at the limbus. And this is additionally reinforced. I'm using a 7-0 vicryl suture here to secure the tenons tissue at the limbus. You can use 8-0 vicryl also. And once all the sutures are taken, the amniotic membrane is then usually always combined with a tenonplasty. It's never like a tenonplasty is done as a standalone procedure, since there'll usually be an epithelial defect overlying it. And this is we're draping the amniotic membrane from lid margin to lid margin. There are different instruments that actually help you get the amniotic membrane in place. You can use a muscle hook. You can use a conformer after placing it on the ocular surface, as I shall show in the next video. You can use the back of a forceps to iron the tissue. This is the membrane that is being secured with fibrin glue, both on the undersurface of the lid, going all the way to the fornix and then onto the bulbar surface. So it's a lid margin to lid margin amniotic that is being placed after doing a tenonplasty. So that's what I was saying, the back surface of the forceps that helps you to iron out. So you ensure that your fornices are well formed. Always remove the speculum when you do that, so that the speculum is not really hindering in the way of either your tenonplasty or your amniotic membrane placement. That's something that we keep doing. Remove the speculum, put it back so that you know that you have good access to the fornix, and then place it back to ensure that you also have good visibility till the fornix. So this is the amniotic that is now being placed. And after the amniotic is placed, the next step is to do an alloslet in this eye, because when you have such a large epithelial defect from lid margin to lid margin, there's really no source of epithelium on the surface that's going to allow the surface to epithelize. So this is being reinforced by placing cells. And here I'm also using some amount of additional conjunctival tissue, which we were able to harvest along with the alloslet. And so these are the alloslet preparation, and then putting it on the surface using fibrin glue. And as you can see in the picture, the lid margin is also charred and burnt. There is a problem with lid closure. And even if it weren't, we normally always finish the procedure by doing a tenonplasty. I've placed the BCL on the surface now. And here, because the surface was also a little dry, we combined it by just touching the puncta with a punctal cautery. In this situation, not usually required in patients with chemical injury. And removing all the excess of fibrin glue, you can see the ischemia under the tarsal surface also. Here I'm trying to approximate the lid margin and see whether the lid is really closing, so that we address any exposure related issues. And finally closing it with tarsorrhaphy suture. This is a temporary tarsorrhaphy using 50 proline, so that we can subsequently open it up and evaluate the healing process in this eye. So this is one example. This is another patient. Actually, this is a surgery that's being done by Bhaskar. And you'll again see the extent of ischemia here, but the steps of surgery remains just the same. One of the things that you want when you're doing a tenonplasty is to actually see the bleeding occurring. That's when you know that you have got viable tissue. And here you can see the relaxing incisions that are being made, because this is a well-formed globe where you need to have those relaxing incisions to bring the tenons to the limbal area. And the same process, basically, whether the surgeon differs or not, the technique is the same. You use fibrin glue and then the sutures to place it at the limbus. And then again, the same works to the amniotic membrane. You can see him actually put a conformer after putting the amniotic membrane, so that it actually helps the spread of the amniotic membrane on the entire surface. After which you remove the conformer and then complete the procedure with an alloslet and tarsorrhaphy. This is another patient that I wanted to highlight. Again, I'll just show a few steps. So this was again a patient of bilateral chemical injury, where I think I'm doing an alloslet in one eye. And what I want to, yes, this was the eye that I wanted to show, where there's a localized scleral ischemia, removing all the necrotic tissue over here first. And subsequently, through the same thing here, you need to advance the tenons only in this particular quadrant. And the rest of it, since we're combining it with an alloslet, we are getting off the pannus tissue. This was a patient who came around 3 weeks following the chemical injury with a epithelial defect that was still present. And that's the tenons that's being separated from the overlying conjunctiva, where once you do that, and then you just give, here we're also combining it with the peritomy, because we want to put in the amniotic and then the alloslet pieces over the amniotic. Cut off all the necrotic tissue in this area. And once that is done, you will go ahead and do a tenonplasty in that area. Same thing again, we're forwarding the tenons tissue using fibrin glue to secure it. And then this will further be reinforced with the help of sutures. That's what the same 70 vicryl suture. And at the end of surgery, this is placing an amniotic membrane. But then here we have enough of healthy conjunctival tissue to tuck the amniotic membrane inside. And this is then followed by placement of the slit bits and a contact lens, and doing a tarsorrhaphy at the end of it. So basically different scenarios to show tenonplasty. This is the tenonplasty that we've done. I think it's almost 10 years now in a patient of tuna injury where there is a chunk of lime in the superior fornix. But basically to highlight that once you have excised all this tuna and the non-viable tissue, then you go ahead with the tenonplasty as I've already shown. And stick it with the fibrin glue. If you don't have fibrin glue, also not to worry, the suture itself will do the job. And this is followed by placement of an amniotic membrane. So this is just to show different case scenarios where we have used tenonplasty. Again, just to show some pictures of chemical injuries where we have done it tenonplasty. And this was, I think, in one of our cases in that publication where a global ischemia, this is how it healed post tenonplasty. That was the time we were not doing alloslets. And this is a patient bilateral injury who has been maintaining a vision of 6/9 with a Boston type 1 K-Pro in the operated eye. Some of our publications that talk about tenonplasty and chemical injuries, but that's only one small aspect of chemical injuries, which definitely needs the kind of attention that it deserves for a good outcome in these cases. I think with that, there are any questions or anything, we would be glad to take it.
I'll hand over to Jayesh and Prafulla for initiating the discussion, if you can.
Yes. Good evening, everyone. I hope I'm audible.
Yes, you are, Jayesh.
Right. So, nice presentation by Dr. Sapna and very nice demonstration of tenonplasty through the videos by Dr. Geeta here. So, before I make my own comments, any of the panelists have their own insights on either the article itself or the broader subject of tenonplasty, and even wants to make any comments?
Yeah, if I could just speak, I mean the concept of amniotic with tenonplasty actually is not unique, because when you are dealing with a deepithelialized surface, you will always obviously cover it with an amniotic. You're not just leaving it by just pulling the tenons and waiting for the inflammation to kind of still go on. So in that sense, in terms of a concept wise, they have pushed the article as a newer surgical technique kind of a thing, which is actually not new. It is something which is being done day in, day out. Second, they did not classify the grade of injury. Even though they gave a limbal deficiency, they have not mentioned the extent of conjunctival defect. Again, the extent of conjunctival defect, the extent of corneal epithelial defect, the extent of limbal deficiency, extent of spiral ischemia, extent of exposure, all this together decides the outcome. The aim in an ischemic eye is only to get a vascular pedicle there and it will epithelialize. So the difference when you look at Rhimes' article and when you look at the other articles probably boils down to the severity of cases which were taken. Again, Rhimes' article was done at a time when amniotic was still nascent. It was just kind of being started. So they might not have used amniotic as a standard of care once they did tenonplasty. They were looking at salvaging the eyes in that point of a time. And even at that stage, they've actually gone ahead and looked at how many eyes they were able to visually rehabilitate, kind of a thing, when they have spoken that PKs doesn't work. Whereas this article talks about a very small subset and it limits itself to just saying that it has worked and kind of trying to say that amniotic adds on to a certain extent. Yes, it plays a role, but when you have multiple other effects that also need to be added in. So the grading should have actually been there and not the this thing. You should at least probably, after almost about 20 years of Dua's grading being mentioned, articles should at least mention some evidence, because we know grade 4s do not behave in a similar manner. So that should have probably been there in the article to begin with.
Yeah, I think all of those are quite valid points. I think there are basically two ways of looking at this discussion. One is from a clinical practitioner's point of view. So for starters, to use it as an excuse or a framework to discuss this topic of tenon's advancement or tenonplasty. I think it's fine that we take this article up and everyone gets the broad message that it's a useful technique and they should do it. However, if one was to do this as an actual journal club with residents or fellows, and if one was to, one would not really take up this article because it has so many flaws. As you rightly pointed out, this is not new. So as far back as 2008, the exact same technique using both Tenonsplasty and amniotic membrane has been described by Dr. Shepherd Singh's group. The Tenon's advancement concept actually goes back to the late 80s. And there are multiple flaws with the way they have defined ischemia, the way where I don't see the word tarsography being mentioned anywhere in the article. In 2020, using these kind of gradings, not even mentioning angiography, I wonder how it adds to the existing literature. And later on, as you said, the later consequences such as LSCD or simlifron, all those things have not been described. But I think perhaps the aim here is to just sensitize people to the role of this procedure in this condition. And as far as that goes, it serves the purpose. As far as the quality of the article goes, there's a lot to be desired, and maybe one would wonder if how it got published. But that's besides the point. I think there's a specific request on the chat box that I see for Dr. Sayan Basu about his recent publication on scleral ischemia and whether he would like to elaborate about the concepts that they discussed there.
Thank you, Jayesh. Good evening, everyone. Wonderful presentations to begin this. Like Jayesh said, the format of this is a little bit different from what we typically consider as a journal club, but I'll go with the flow since we are discussing about the general topic of tenonplasty, tenon's advancement in the treatment of severe burns. Couple of things that I think is important for everybody to understand, particularly, the tenonsplasty, the technique, as Dr. Geeta very elegantly showed in her videos, is otherwise relatively straightforward. You're just loosening the tenons, releasing it from whatever other remnants of the conch you're giving, releasing incision, putting it close to the limbus, and either gluing it down or suturing it. I think in the broader context of the treatment of burns, it is important to understand a couple of things. First of all is that when we say ischemia, ischemia means different things to different people. So most of the cases that you saw here are very severe, extreme examples of ischemia. And probably in those cases, this kind of an approach as a desperate attempt is fine. But I think we should not, miss the woods for the trees, which basically means that when you are the important things to do when you're treating, I was just a few days back on Sunday, I was in Ahmedabad with Jayesh, and Dr. Fogla was also there. I don't see him today, but we were discussing about keratoconus, and I liked something that Dr. Fogla said. We were discussing about the management of keratoconus, and he said that, look, the main treatment of keratoconus is contact lenses. And this is what you need to communicate to the patient very, very well and right at the beginning. Everything else that you do is adjunctive. Okay, so in the same way, the treatment of acute burns is medical. And what is the medical treatment of acute burns? Like Geeta was showing initially in her presentation, is very important for everybody to understand that is the mainstay of treatment of burns, that you need to give topical steroids, maybe even systemic steroids. I think I liked one of the important things that was there in the INEs that prevent exposure, either putting a contact lens or doing a tarsography. These will go a long way in treating the acute condition of burns. Everything else that you do is adjunctive. So they will contribute a little bit more on top of that. So one of the main criticisms of this particular article is that they've done tenonsplasty almost as if it is as an alternative to everything else that is more important in the treatment of burns. So if you do tenonsplasty and give the patient doxycycline, but not give the patient steroid, then it doesn't really make any sense, because it's very counterintuitive. And you cannot recommend this to anyone. So again, a couple of other things. For example, ischemia. I mean, the only way to understand or evaluate ischemia is by doing angiography. And if you are not doing angiography, that is the main limitation. One of the questions that Dr. Swapna had at the end of her presentation, I think they were quite relevant, as to why I can't understand ABCD. You can't understand ABCD, and all of us have this problem in acute burns. Is that, first of all, it is such a heterogeneous condition. Every case of acute burns, even in the same patient, the two eyes are very different, because the amount of chemical that has gone in is different. The force with which it has gone in is different. The amount of time that is had to expose on the ocular surface is different. The concentration is probably different. When you're washing it, the amount of exposure was different. And if you look at inter-patient, then you're adding a confounding factor in every patient, because no two burns are the same unless many people got accidentally injured at the same time. And even then you will find heterogeneity in that population. So that's number one. So ischemia is a very broad general term, but there are very grades and levels of ischemia. And unless we have a reliable way of doing angiography, we have, but it's not very commonly available. It's very difficult to understand it as a disease. And number two is that in the treatment of ischemia, all of the other things are far more important than the surgical component. I would say the most important surgery in the treatment of acute burns is actually tarsorrhaphy, which is least frequently done. So if I was to say one thing, that, if you are treating acute burns, and particularly burns of this severity, please do this. I would say, everybody, please do a tarsorrhaphy. Whatever you do, whether you're doing a tenosplasty or an arrow slit or just an amniotic membrane graft, please do a tarsorrhaphy. That is probably the single most important surgery in the treatment of burns, in addition to the medical treatment. That is not negotiable. You have to give the treatment, the patients, the medical treatment that is part of the INEs. And I think that to miss the woods for the trees is I think a lot of patients suffer, because we are looking for, or we sometimes think that an amniotic membrane is a panacea or a tenosplasty is a panacea. It's not. I mean, these are far more complicated cases than you can solve with just one surgical procedure.
Yeah, excellent points. There are two specific questions related to the surgical technique. So maybe Dr. Geeta here could take that up as she demonstrated the surgery. One is regarding which speculum you would use for this surgery. The other one is whether it's possible to use dry amnion for this procedure as well, and how you would orient the amniotic membrane, which side up and which side down.
So to answer the first question, the speculum that we are using in the surgeries that were demonstrated is a simple wire speculum. You can use any speculum. There's no speculum that has to necessarily be particularly used in this particular, in these eyes. And as far as amniotic membrane is concerned, we do prefer the cryopreserved over the dry membrane. And whenever you place amniotic membrane, in most instances, it's the epithelial side up. What we use is denuded amniotic membrane. And so you have the stromal side, which is below, and the epithelial basement membrane side, which is facing above. So I would just like to point out one particular, I don't know if we can go back to the presentation by Sapna, just to show the case 10 in that particular paper, just to show and maybe take forward what Dr. Sayan mentioned, and what I started off by saying, that there is no I or E in the list of I's and E's which is more important than the other, or which needs to be specifically addressed. So what I was trying to show in this, in fact, is that this particular picture, the A picture, if you look at it, it describes this as scleral ischemia, which is present from 2 o'clock to 5 o'clock or something like that, inferonasally, inferotemporally, yes. But if you just look up and you see the upper lid margin, it's kind of just completely blanched out. That's a white, I don't know, the upper lid margin that you can see in this particular photograph, yes. So that's absolutely whitened, what you can see here. And probably there's a very high possibility that if you actually evert the lid and check, there's going to be an underlying tarsal defect also over there. And you may find that these are sometimes issues which, if you don't evaluate when you are looking at these eyes with chemical injuries, you can have an issue with symblepharon formation if you're not going to be putting amniotic, in case you have two opposing raw surfaces. Ultimately, it's two opposing raw surfaces that lead to issues of symblepharon. You can have that lid margin actually just necrosing off because it looks so ischemic, and that might have been the cause for the entropion that was seen in some of these cases. You can stop sharing if we have had that. But then the post-op later on picture, you can't see that part of the lid, but it does look to have healed over a period of time. But there are all these factors that need to be assessed. And even when you're assessing, if you have the list of eyes and E's in your mind when you're looking at these patients, you will not miss out on any of the parameters which can have an adverse effect on the healing process. Ultimately, your aim is to epithelize the ocular surface as quickly as possible after the chemical injury, so that you don't end up having a corneal stromal melt. You don't end up, God forbid, you don't end up having a corneal perforation, because these are situations which can completely change the prognosis and outcome in these eyes. And this can be done by achieving a quick epithelialization of the ocular surface.
Right. So there's a question by anonymous attendee, it says here. Is there any role of AMG beneath the tenons?
Might not add if you're going to be anyway placing an amniotic membrane over and you want the vascular pedicle to be flush with the sclera. So you may not lose anything by placing amniotic, but then it's probably, you definitely need amniotic over the vascular pedicle than having a double amniotic. Whether it's going to really add on to any additional advantage, I'm not very sure of that. But then putting it under the tenons and then not having an amniotic over the tenons is probably not done.
So Dr. Nikhil Gokhale, you have a question? Go ahead and ask it. Please.
No, I was just asking, means in a private practice, you often find patients who have either somebody has done an AMG alone, somebody has done an AMG with tenonplasty, and somebody has done AMG tenonplasty and then done a alloslet as well on first day or second day of burn, or immediate post burns. And then you look at the grade of injury. Sometimes they correlate, sometimes they don't correlate, or you feel it's overdone or underdone. So can the Sayan and Geeta, they give us some tips on what are the optimal grade of burns where we should do 1, 2, or 3, or together, because that's where I think many of us find it difficult to figure out. Should I do it today, or if the AMG fails, then do a tenonplasty? Is it really ischemia which requires a tenonplasty, or is just an AMG will manage it? So are there any tips that we can give to our to all of us? We can get some tips from you.
I think what is, Dr. Nikhil, what is kind of internationally followed by most people is that when you have a patient who has come in an acute burn, and I think it's important to emphasize here also that when we say acute burn, we are talking about patients who just had an injury and come probably within the first few hours, or at the most within the first few days. There is a big difference between someone who you are seeing immediately after injury and someone who you are seeing a few weeks after injury. So first, that distinction needs to be made, that we are talking about patients who just had an injury and are presenting to you after a few hours, or at the most within a few days. So in these patients, I think everybody will agree that, like Dr. Geeta was saying, that examine the patient well, look at the lids, look at the extent of the epithelial defect, look at if the integrity of the globe, and stain the surface, look at the size of the defect. If there is any debris that needs to be cleaned, clean it, do the irrigation, neutralize the pH, start the patient on hourly, half-hourly prednisolone acetate, put a bandage contact lens, and so on and so forth. And how we manage these cases is by serial follow-up. So you need to see the patient again after a couple of days and see, is it getting better? And if it is getting better, if the epithelial defect is getting smaller, that's good. Okay, so you follow that patient again after another 3 days. It's gotten even smaller. So, that's good. You can just keep on with the medical therapy. And if that healing stops at a particular time, that the epithelial defect is now not getting any smaller. Okay, or right at the beginning when you started medical therapy, when you saw him after 2 or 3 days or saw her after 2 or 3 days, there was no change in the defect. That is the signal that an adjunctive element needs to come. That can be an amniotic membrane only, that can be an amniotic membrane with a tarsorrhaphy, that can be an amniotic membrane and a tenosplasty and a tarsorrhaphy, that can be an amniotic membrane and a tenosplasty and a tarsorrhaphy and allograft, depending on how severe the injury is, how deep the burn is. And there are many clues for that. If you have a view inside the eye, in most cases we don't, but if you can just see that, you can see a hypopyon or some amount of iris atrophy, you can see the anterior chamber is full of cells. That kind of indicates that there's a deep ischemia, and then you need to add one on top of the other. So you know that, okay, in this case, an amniotic membrane alone is not going to do an amniotic membrane plus star. So like also what Dr. Geeta was saying, that you need to make a subjective assessment of what is the reserve on the ocular surface. Is there enough conjunctiva for it to conjunctivalize even? And if not, maybe put in some limbal cells and so on and so forth. But this serial evaluation to see what is the response to medical therapy is very vital. If we don't do that, then what you're saying, it happens quite a lot that we tend to overdo surgical management of burns.
I can see that Dr. Himanshu Patilia has his hand up. Yes. And then we'll come to Dr. Bhaskar. Yes.
Couple of points here.
Yeah.
What Geeta spoke about the speculum part, and I think she touched upon that during video also, that it's not just speculum. Also, we actually sometimes use lid suture or lid retractors and speculum also to reach to the phonacial region. All those things, lid sutures or lid retractors are much easier and much better. Once you put a suture there, amniotic membrane there, then the speculum helps us to spread it nicely and to get an access in the periphery much better. So changing over between lid suture and speculum can actually help. So initial part, retractors or lid suture, later part speculum can actually help in many of these cases. Also, it depends upon how bad the lids are. If lids are charred, passing suture through that may not be very easy. So there, the retractors may actually help. The other point about what Dr. Nikhil was asking, when to do what, we have to understand what we want to achieve from each of that treatment, what we are doing. Like if we have charred tissue, what Geeta was showing, those kind of tissue, no epithelial based treatment or no stem cell based treatment or not even amniotic membrane is going to help you. So covering that kind of area with any of those things is not going to help. What are we trying to achieve there? I mean, what is the goal there? We have to ask that simple question. Now, in such kind of cases, when we debride that area, and it, as Sayan rightly said, we have to evaluate each case. And in that case, if you feel that it's really blanch and it's really bad enough for you to have anything which can grow there, whether it's conjunctiva or whether it's your slit pieces or something, then it has to be covered with the tenons, and there you have to advance tenons now. And the tenons there is for both surface. It's for undersurface for your sclera, as well as something which is going to grow over top of it, and where you are covering it with amniotic membrane and then replacing with or adjuncting with your slit pieces. And for that, you will need advancement of tenons. So based on each case, when you see what you want to achieve from that particular treatment, well, you can decide what you want to do. And sometime post-operatively, it may be unfair on our part to know what primary surgeon would have seen on table. So, sometime we may have to possibly accept it that primary surgeon would have taken the decision based on what they felt best.
Right. Yes, Dr. Bhaskar. I think you can make those the closing comments also. We seem to have overshot our time, but please go ahead.
Yeah. So two things, even when you're talking about a chemical injury, how a thermal injury behaves and how a chemical injury behaves is different. So in a thermal injury also, you might suddenly have a significant scleral melt because the collagen undergoes lysis just by the heat. So you might actually see a epithelial defect come in and you might feel that the patient is healing, and then you call the patient after a week's time and he comes with a significant melt in. So thermal injury patients need to be followed up a little bit more closely till the entire epithelium heals over the collagen, because the collagen is degraded by the heat that accompanies a molten metal which is there. And the figure 10 that was shown was also a molten metal aluminum kind of a thing. So that tends to cause significant collagen lysis. Even in the lids also it causes significant damage as compared to a pure chemical. And coming to Dr. Nikhil's question, basically the difference is he was trying to ask if we see an acute chemical injury, whether we want to do an amniotic alone or we want to combine it with a tenonplasty. If you have a very severely ischemic surface, which is absolutely white, there is no problem. But the problem happens when it is not as ischemic, but you're seeing a little bit of chemosis, which kind of gives you a feeling that there is ischemia, but there might actually not be ischemia. A simple trick could be just snip the conjunctiva in that area. If it bleeds, there is vascularity, you just need to do an amniotic. If you feel that you're snipping and it is not bleeding, and there's one focal area where it's significantly more whitish as compared to the rest, you're not able to see trace the vasculature in that area, then you will have to go ahead with a tenonplasty in that quadrant.
Jayesh will also have Dr. Maninder, who is going to talk to us.
I was just going to ask you to introduce him if possible.
Yeah, so Aditya, you can just invite.
Yeah, so Dr. Maninder Setia is a dermatologist and has a keen interest in epidemiology and statistics. So with that, I would like to request him to share his screen, please.
Yeah, so should I start sharing my this?
Yes, please. Yes, please.
It's not allowing me. Is this okay?
Yeah, we can see it.
Yeah, so it will be a short, quick discussion. I know you've already been through a lot, and probably surgery and journal articles and clinical stuff is important, but I'll just go through briefly. The topic I was given was how to select a journal. I just have 2 slides. So most of the times, the way things are and the way I would like to do it is like, so the relevance of the journal to the topic. So either there are some generals, there are some specialty journals, or there are some general journals. So for example, today's article was in the Journal of Burns. So was it an ophthalmic journal or was it a Burns journal? So it was a Burns journal, right? Like an ophthalmic. So would you consider that to be a specialty journal or a general journal? So these are the kind of things. So sometimes you may find very important articles which are relevant to your clinical field in general journals or journals that are tangential to the topic, like the clinical field. So you can go for either journal. Then the other thing that usually people look for is the impact factor of the journal. Now, there has been a lot of discussion around impact factor. So there are 2 types of scores now. There's an impact factor and there's a site score. So impact factor is based on Web of Science, and site score is based on Scopus journals. So there were a lot of issues around the transparency of impact factor, because impact factor does not take into account all the articles published in the journal. For example, case reports, letters, small correspondences are not included in the denominator for the impact factor, whereas site score is more transparent, it includes all the articles. So nowadays, a lot of authors or even in journal clubs, they would like to do both. Like, you would compare the impact factor and the site score of the journal, and you would find that there is quite a variability in the impact factor and the site score. I don't know. Sometimes the best articles are written in journals with low impact factor. It doesn't matter. And for a researcher, probably it's the H index that matters, which is how many times your article has been cited. So sometimes when you go for a journal club, maybe you can talk about the impact factor of the journal, the site score of the journal, and even the H index of the primary author. Like, what is the scientific merit of the article that we are studying. Then maybe go through some recent issues of the journal, then check the type of articles. This is for publication mostly. Open access and closed access journals. Now here, most of the journals traditionally were closed access. You could not access the full article. Now there are certain guidelines that if it's an NIH funded project, then it has to be an open access article. The journal may not be an open access journal, but the article has to be an open access article. So the idea of an open access article is that you have an access to the whole article. Open access journals or online journals only have online versions. They do not have, I don't know whether there is a real pros and cons of having a closed access or an open access. I mean, does it mean, I don't know whether if the article is in an online journal, whether it's a poor quality article or it's a good quality article. Usually I think it all depends on the article. In fact, if you do a systematic review or meta-analysis, I mean, when you learn systematic reviews and meta-analysis, one of the exercises you have to do is, two people have to abstract data from the same article. And you'll be surprised that two people actually abstract really different data from the same article. So the primary author abstracts the data directly. The secondary author of the meta-analysis is blinded to the name of the journal and to the name of the authors. So because there is an inherent bias in us also, if it comes from a good journal or if it comes from a very well-known author, we tend to be like, tend to accept more or something like that. So I guess it all depends on the thing. Indexing of the journals. So the traditional PubMed index, now there's Scopus, there's directory of open access journals, and there are tons of indices now, Copernicus and things like that. But the traditional ones are PubMed, Embase, Scopus. These are the traditional ones. And some of the best known groups of publications, the BMC group or the PLOS group, and even now the BMJ group has all open access journals or only online journals. Like BMJ Open is just an online journal and it publishes articles regularly, and it's a pretty well indexed journal. So I think these are just few points. I know you're really way above the time, and I think we should just end over here. It's time to have dinner now.
I'll just ask one question. Just
Sure.
one point. Many times we just write without even thinking about it as a prospective. This article, they claim prospective study. Now, isn't it true that for any prospective study, you would have study protocol, you would have things which you're going to study, which you'll define, which your outcome measures you will be defined. So your data would be much complete. Whereas most of the articles, if you see, they are actually not prospective, but the authors always claim prospective study. I mean, how to deal with this thing?
I don't know. I mean, I agree with you that if it's a prospective study, that means you've designed the study de novo. I mean, you're collecting data from now onwards.
Correct.
Retrospective would mean that you're already you're analyzing the data or designing the study from data which are already present. True. So the chances of missing data would be much higher. The chances of this. So I mean, if the authors say it's a prospective study, how can you? I mean, do you want to question the authors, or how do you do?
There should be a way to
prospective study.
Yeah, I think they should, because many authors unnecessarily claim retrospective data analysis as a prospective study, which is not true.
Well, one good thing, I'm not sure. Sorry, I'm not sure if I found the word retrospective or prospective in this particular paper, because I actually didn't find. I specifically looked for it and I didn't find either of the. I didn't find the specific study design, so I'm not sure if I am. Please correct me if I'm wrong.
Whether they claimed it a prospective, but yeah,
whether the paper mentions whether
one
it
of the. Yeah, one of the ways you can look at it now, there is now most good journals require the date and the reference number of the ethics approval. Yeah. So in a prospective study, the ethics approval has to be before data collection.
True. Yeah.
in a retrospective study, the data are from the previous years. So that's one way you can check for the prospective or the retrospective nature of the study and whether have the authors correctly written the nature of the study. I don't know in this article whether they have written the reference number of the, like most good journal groups now want you to give the date of ethics approval and the reference number of the ethics approval and the name of the committee that gave you the approval. So that's one way of cross-checking.
Yeah, correct. I think that's a simpler way, as you said. Yeah. Thank you.
Sure. Thank you.
So Jayesh, you want to conclude?
Yep.
Nikhil, you want to conclude?
So that was I suppose that is that for the first journal club under this series. And I'm sure we'll learn a lot from this and keep on learning about how to run the journal club, including, of course, the journal articles. So thank you all very much for being present and looking forward to the next session already. Thank you.
Good night.
Thank you.
Very good.
Good night, sir.
So Shabina, we are not online, right?